I'm going to get started. Thank you very much for joining us. Good afternoon. My name is Matt Vallière. I'm the Executive Director of the Patients' Rights Action Fund, or PRAF, for the benefit of some of our allies with disabilities. I'm an early 40s man of color, black wavy hair, black trim beard, olive complexion, and I'm wearing a pink checked shirt with a sky blue blazer, and I have a white background. So today, we're hosting a webinar. It was titled Patient Impact of Assisted Suicide Laws. So we're kind of looking at the various ways in which vulnerable people and people who experience the medical system in different ways would experience difficulties or vulnerabilities and ultimately pressures because of assisted suicide laws being on the books. So we'll have some personal stories. We'll have some thoughts for you today from experts. We're very, very pleased to bring together this interesting group of folks for today's webinar. It's an honor to host this webinar. Wonderful advocates and friends. I've worked with different ones of these folks, some for years, and so I'm just grateful for each one of them for their time and their willingness to both advocate on this issue, but also to share some of their personal stories. So we first have Patty Mouton, who is the Vice President of Outreach and Advocacy for the Alzheimer's Association of Orange County. We also have Jules Good. They're the founder and consulting lead for Neighborhood Access. Vikki Vickers is the program director at Central and South Los Angeles ADRC, Communities Actively Living Independently and Free, CALIF, which is an independent living center in Southern California that serves Los Angeles County. We also have Heather Weininger, Executive Director of Wisconsin Right to Life, as the Executive Vice President of the American Academy of Medical Ethics. So a little housekeeping. You should feel free to put them into the Q&A function. So if you move your cursor around, you can see the toolbar at the bottom. There's the Q&A option with little bubbles above it. If you click that, it will bring up an opportunity for you to type in your questions. So please ask any questions through that. And for those questions that we have time to take at the end, we'll be able to verbally say those, and then the team here will answer them, and any questions that we don't quite get to, we'll do our best to get back with you about them afterwards, a follow-up. So the session is going to be recorded, and we'll share a link on our platforms afterwards. If you are from the media, you have a media request, please contact Bill Pierce at WEIERCE@APCO worldwide.com. That's APCO worldwide.com. So panel and host, for anyone who's not speaking, please do keep your mic on mute. And if you can benefit from closed captions, to turn them on, again, if you move your cursor around, you see the toolbar at the bottom. It will show an option that says closed captions with the closed caption symbol. It's a square with C, turn on or turn off up arrow, and it has different options for the closed captions, which you can make them bigger, this kind of thing. So, and with that, I think we can get started. So, Patty, please take it away.
Well, thank you very much. It's really a pleasure to be with all of you, this really wonderfully august panel of experts that I'm feeling very privileged and honored to participate with today. A little about me. I've worked in dementia care for over 25 years, and prior to that, I spent a number of years in hospice care. Among my academic pursuits, I have a degree in palliative care chaplaincy, and I really want to just say at the outset, I'm opposed to any kind of physician-assisted suicide, no matter how it is described. And I think a real danger in the semantics of all of this is the way the terminology is trying to soften it so that it doesn't sound as horrific as it actually is. I really hope to spark some thoughtful reflection and conversation on this issue, because what I see as among the really strong and top of mind dangers include that for people who have expensive care needs, those with dementia, the danger, especially for those whose continued care might be considered burdensome by their families who hope to inherit part of the estate, they might feel like people have a duty to die on time or a duty to die before all the money is used up. I believe the potential for abuse of this care option is really, really high. And I think it's unconscionable that we aren't looking at that straight in the eye. People who are vulnerable need to be supported, and their life is valuable no matter what kind of disease process they're in, or no matter how intensive their care requirements are. They're not diminished because of disability. And if you talk to people with disabilities, they're very concerned about this growing movement to expand access to physician-assisted suicide, because it's particularly poignant for people that aren't perfect to start with, or aren't perfect as many of us would define it, because there's perfection in every life form. I really, really am sure, based on my experience here in Orange County, that most people do not understand how effective good palliative care is. They don't understand how to get access to good palliative and hospice care. They don't understand that it identifies and treats all forms of suffering. We don't want people to suffer. Pain and suffering should not be left unmanaged, and it's pretty negligent if people are left to suffer the intractable pain that proponents of assisted suicide seem to tout as one of the major notions that should make it available to people. People need to talk about all of this, and physicians can now bill Medicare for this conversation about end-of-life care wishes. So there's no excuse for it not to happen. And it is irresponsible of the clinical community to not initiate these conversations and make people start to think about it. People don't understand about ventilators. They really don't understand that CPR really is not as effective and impactful as people think it is. It's not like on TV. You don't have cardiac arrest, have the crash cart come in, and everybody from George Clooney to Juliana Margulies and all of the stars that are on ER and Chicago Hope and all of the different medical shows. It doesn't work that way, that you have cardiac arrest, CPR, and 30 minutes later you're having a cheeseburger and a beer with George Clooney. It doesn't work that way. People need to understand that. I believe that the time surrounding end-of-life care offers many opportunities that people also don't often anticipate. We can have caring experiences, rapprochement, love and care can flourish. Spiritual and emotional epiphanies are possible, even with people who have limited responsiveness. Healing can be a treasured part of serious illness and terminal illness, and it doesn't necessarily have to be the physical healing. So I think we're missing that point too. This is an evil. Making death, untimely death, available to people in this way is an intrinsic evil. And physicians should not be put in a position of killing their own patients. And that baseline evil is not always addressed. It's couched in terms and cloaked in this autonomy and being able to decide for oneself. Well, it's playing Mother Nature and it's playing God. And I do think that this is an inappropriate use of clinical skills. It's contrary to the dignity of the patient themselves, because if the patient has been reduced by suffering to a position where this person wants to kill himself or herself, then we've already passed the point where there's been a failure. And the solution is to undo that failure by relieving the person's suffering by killing them. I don't think that that equation balances. And in people with dementia, this is a particularly dangerous attitude to think that, as is discussed in a recent article from the Journal of Geriatrics, the American Geriatric Society, talks about medical aid in dying to avoid late stage dementia. That in and of itself is appalling that we will be discussing it in this way. Dementia is a part of life. It's not normal aging, but it does happen to 50% of us who reach age 85. So does that mean we just usher all those people off the planet because they have a dementia diagnosis? I think not. The disease progression is predictable in most forms of dementia, and the signs and symptoms when they are at end stage, not desiring or having difficulty with eating and drinking, means tube feeding could be bypassed. We don't have to foist interventions on people who don't want them to artificially prolong life, but neither should we be looking for ways to extinguish life where there is still possibility for quality of life, where there is still possibility for some healings, spiritual, emotional, existential healings can take place. And I don't think we should be in the position of finding new ways to help people end their lives artificially. So I am opposed to physician-assisted suicide, but I am particularly opposed to the loosening of the regulations in many of the states that currently have this as a legal option. The people with dementia do not meet those 3 statutory benchmarks that, for the most part, in states that have legalized assisted suicide, where they have capacity to make the decision, where they are terminally ill and they can self-administer the medication. It's wrong to loosen those standards. And I can tell a very personal story that I heard from a physician who participates in physician-assisted suicide in Orange County. And I won't name her just now, but I can if anybody would like to contact me. And she discussed a situation where the patient was now too weak to lift the glass and drink the potion with the lethal drugs in it. So she had it administered through a tube rectally. And the patient could then just lean on the plunger. Now, I found that to be anathema and frightening, that we're cooking up ways, dreaming up ways to further enable people who do not meet even the criteria in this very, very unfortunate law. And for those of you who don't know, physician-assisted suicide initially in California was killed in committee. It was dead. The people didn't want it. All of the elected officials engaged in the committee work for this bill initially in about 2015 killed it. It was brought back in a gut and amend example of heinous political brinksmanship and inserted into an emergency Medicaid bill in California. So it didn't go through committee where it had already been killed. So I think many times these laws are being enacted through various ways that are not straightforward and transparent. And so I object on that basis as well. Thank you for the opportunity to discuss this really important issue. And I particularly want to say that in 25 years of doing dementia care, there is so much that happens toward the end of life, even when people are just minimally responsive, they are there. They are present to enjoy and experience the loving care that they are given. They sometimes are nonverbal for months, and you do something lovely for them, and they say thank you, or they smile, or they respond in some way that lets us know that even in the face of this abject disability of end-stage dementia, there is quality of life, there is loving and loving care, and I think we all are to benefit by being part of treasuring and cherishing and valuing life all throughout the stages of dementia. Thank you.
Thank you, Patty. That's a lot of good food for thought, because I think a lot of times, you know, folks are they're looking at assisted suicide laws as a way out of what they fear, in particular with regard to dementia advocates, saying that that's why they're proponents of this, even though that dementia patients would not actually qualify. And so now you see with Hawaii, which is an already legal state, having that would allow folks to opt for this via advance directive, not necessarily knowing what would be ahead of them, and particularly and specifically because of that fear of dementia. So with that, thank you. Jules, please take the floor.
Hi, everyone. Thank you for having me. My name is Jules Good. I use they, them pronouns. Quick image description of myself. I'm a younger white person with short blonde hair. My background is blurred, but if you can tell I'm in a car, don't worry, I'm not driving. I'm just picking someone up from the airport and didn't want to keep them waiting for too long after they land. So I have worked on this issue professionally in a policy context and still do part-time. But I've been asked to share my personal story today as a patient, as a disabled person who has very real personal concerns about what a policy like this would do to other people who have been in my shoes and in more difficult situations as well. So when I was 19, I was in my second year of college in a very rigorous degree program. I was studying music. I was a viola major. I got really sick in between my first and second semester and basically woke up one day with a big chunk of my hearing missing. I obviously was panicked because I was a music major, and was very concerned, thought, okay, well, maybe I have a sinus infection, maybe I have something, there's fluid in my ears, whatever. Went to an audiologist, got my hearing tested. I had lost about 70% of my hearing overnight in both ears. I went then to an ENT and then to like an academic center. Nobody could figure out what was wrong with me. They still haven't figured out what's wrong with me. And I have lost more hearing since that time. So it seems to be like a progressive loss. Around that same time, I was also struggling really hard with anorexia, which I had been dealing with kind of on and off since as long as I can remember, since childhood. And when I was in college and going through this really, really stressful time, that really exacerbated the symptoms that I was having and the restrictive behavior that I was having. I got to a point where I was just exhausted all the time. I was not eating. I was spending like any of my free time at the gym or like doing things where I was just making myself sicker, basically. And it got to a point where I just felt like there was no hope. Nobody could figure out how to help me. I felt like the career that I had chosen for myself was now over, and that I didn't have any options. And so I will spare you the details, but I essentially attempted to take my own life. I was not successful is the wrong word, but I obviously did not take my own life because I am here. And in being referred to counseling after that, for the first time, I was trying to get what I could out of it, and was trying to be as honest with the psychologist that I was seeing in my intake appointment about everything that had been going on. And so I explained the whole situation to her, and was kind of sitting there waiting for her response after I went through my whole spiel. And she basically looked at me and, like, I will probably never forget this for as long as I live. She said, wow, that's really difficult. I would probably want to kill myself if I were you too. Which is not what you're supposed to say as it turns out when you're a mental health professional. And it was a really difficult experience, not only because I felt like, well, because of everything that was clearly going on that was wrong, but also because in that moment it felt like, because I was struggling with disability and with a significant, like, diagnosis, that my suicidality was being deemed as rational. And as I went through college, took a hard pivot from wanting to be a music teacher to going into disability policy work, which is what I do now, the attitude that I noticed toward disabled people is very much consistent. And that is that our lives are seen as expendable. They're seen as lives that will never be as valuable or as worth living as non-disabled people. And that is especially true for multiply marginalized disabled people. And I think about my experience as a white person from an upper middle class background, well-educated, a lot of things going for me. If that was the experience that I was having with the medical system, what was going on for people who were not as privileged as I am and was at the time? And I've been so fortunate to work with many disabled people, some of whom are here, really powerful activists, like Anita Cameron, who's a Black disabled woman, who has had horrible experiences with the medical system and has been written off because not only because of her disability, but because of her race. And that experience is so common for multiply marginalized disabled people. So my point in sharing that story is not just to trauma dump on you, but to say that I think a lot of times we want to believe that the medical system has our best interests at heart, and that doctors are always going to, and medical professionals in general are going to take good care of us and are always going to know the right thing to say, the right thing to do. And that's simply just not the case. There was a Harvard study from a few years ago that found that 84% of physicians surveyed across the US thought that disabled people automatically had a lower quality of life than non-disabled people. So if you're going into a medical setting as a disabled person and your care provider already thinks, wow, your life kind of sucks, do you think they're going to try as hard to save you, to prolong your life, to do things that can make your life better? No. And that's been shown over and over again. There have been so many cases where people have had care withdrawn prematurely, have had care denied. And a policy of assisted suicide really ups the risk that systemic ableism, systemic racism, and just systemic disregard for the experiences, the real experiences of disabled people will end up being fatal rather than something that somebody tells a story in a webinar about, right? When we talk about assisted suicide policies, people say, well, there's all these safeguards to prevent coercion, and, you know, like doctors aren't in these examination rooms like telling people to kill themselves or feeding them these pills. And I think the point that I want to make to those people is that they don't have to. We are already told by society on a daily basis, through words, through the fact that so many environments are not accessible to us, through just attitudes about disability in general, that we're a burden and that we don't belong in the places where other people belong. And also the financial aspect of things, you know, it's not just financial coercion in terms of like potential beneficiaries who might inherit money off of someone's death, coercing them. That's like a super direct, like Hollywood level of coercion, right? Which does happen, but it's even more subtle in terms of like, well, if my insurance denies a claim for a treatment that would maybe isn't curative, right? It won't cure my condition, but it might enhance my quality of life. If they deny that, but they would approve a claim for assisted suicide, that's pretty much made my decision for me, right? So it's really important, I think, that we listen to the experiences of people who have been most negatively impacted by the medical system when we're considering these policies. And I don't think that that's happening at the legislative level. And if we're thinking about this as an issue of choice or autonomy, autonomy has to be available to everyone. And people cannot make free, uncoerced choices about their care when they are constantly being told that their lives don't matter. So yeah, that's all I have to say, I guess. Thank you.
Thank you, Jules. This is really I'm sorry, I had to go through all that, and that I understand and have also experienced some of the difficulties of the medical system. It's just putting assisted suicide on the table in the context that we find ourselves in can only result in some people being discarded. And people, human beings, have equal human worth and dignity and ought not to be treated like that. So thank you. This is why, to your point, it's not just a story in a webinar. This is why we do what we do. This is why we advocate so hard, why we fight so hard. Vikki, would love to hear from you.
Ah, my goodness, Jules, I'm so sorry. Well, I guess I'll start out with my own backstory, which is still to this day a little confusing to me also. But, you know, I was always different in my family. I'm an adopted child, the oldest of 8. My mom was a hero, and she hid my disability, a mental illness. I have schizophrenia. For the first 22 years of my life, afraid of what society would do, how they would treat me. You know, I was born in 65. In that generation, mental illness wasn't accepted. But as I turned 22, I had a psychotic event that wound me up in the hospital. And I was started on medications, which at that time in the 80s were horrific. I think it was Halidol and lithium. Which made me shuffle around, drool on myself, you know, have no real control. And I hated taking medications. So I would go on and off medications. My mom would, find me and try and save me. But, people around me after that first psychotic event, really let me know that I wasn't accepted as I was before. And one time, she was actually a nurse at a hospital here in Antelope Valley. And she said, some people like you, they just die. You don't want to take the medication. You don't want to listen to what we say. Some people like you, they just die. And I had thought about that. And I think I was 23 at that time, or 24. And I said, you know what? No, I don't want to take the medication, and I don't want to feel like this. So I took her suggestion and I tried to commit suicide. I took the whole bottle of pills that they had just prescribed. And I remember waking up in the hospital, and this very nice, very small, unintimidating doctor telling me, you know what? You're too young to die. So there's that argument. If I take those pills, I feel like I'm dying anyways. And this lady says, and all my friends hate me now. And this doctor saying, no, you're too young to die. But at the same time, they're going to give me another medication that makes me want to feel like I'm going to die. So it was really awful. And I did that, going over the bumps and roads to advanced medications that I take today to manage my illness. And to this day, I work in services for people with disabilities of any kind and seniors. And I see this kind of stigma hurting people quietly with postures and the way that they interact with people with disabilities, making them feel intimidated or less or of less worth. So, it doesn't always have to be direct, telling you to kill yourself. A lot of times it's just a subtle, constant presence, of the atmosphere that you're in. So anyways, that's just the backstory. So I just want, I will tell you this though, before I make this statement. If I had died, if that one nice, small, gentle doctor had not told me, hey, you're too young to die, I would have missed every one of my nieces and nephews' lives on this earth. I would have missed being there for my mother as she fought for her life and passed. I would have missed being who I am today, somebody I can look in the mirror and be proud of. And I would have missed what I do daily, Monday through Friday, most of the time on Saturdays too, which is serving a community who has felt like me sometimes. And I wouldn't have wanted to miss that. I will fight to my last breath to live, because I believe in my faith. That's what I owe God. Life. Life is to be lived. It is unnatural to fight against the instinct of survival. And I will fight, because Lily Beth Navarro, my mentor and my friend and my executive director who passed in September, she fought for her last breath too. So I wrote a statement because I want to put everything in line as it should be to be understood. So today I sit before you to address a pressing issue that strikes at the heart of human dignity and the value of life itself. The topic at hand is the contentious practice of assisted suicide against people with disabilities. Advocates of assisted suicide often argue that it provides individuals with a choice to end their suffering and maintain autonomy over their own bodies. However, we must carefully consider the potential consequences, particularly for individuals with disabilities. First and foremost, the legalization of assisted suicide for people with disabilities sends a dangerous message to society that some lives are less worthy of preservation than others. This deeply flawed notion undermines the inherent value and worth of every life being, regardless of their physical or cognitive abilities. It perpetuates harmful stigmas and discrimination against people with disabilities, leading to the devaluation of their lives. Furthermore, the implementation of assisted suicide laws poses significant risks, particularly in retaliation in relation to coercion and abuse. People with disabilities are already vulnerable to societal pressures and may be unduly influenced or coerced into choosing assisted suicide, rather than being provided with the necessary support and resources to live fulfilling lives. This raises serious ethical concerns and jeopardizes the fundamental principle of protecting the most vulnerable members of our society. Additionally, the availability of assisted suicide may overshadow the need for improved access to comprehensive palliative care and support services for people with disabilities. Rather than addressing the root causes of suffering and providing holistic care, assisted suicide offers a quick and irreversible solution that fails to uphold the dignity and worth of individuals facing challenging circumstances. In conclusion, I say the legalization of assisted suicide for people with disabilities undermines the very fabric of our society's commitment to equality, dignity, and compassion. Instead of embracing a culture of death, we should strive to create a more inclusive and supportive surrounding that upholds the value of every life and provides the necessary resources to enable individuals with disabilities to live with dignity and purpose. I hope we're able to continue to engage in thoughtful conversations and advocacy to ensure that the rights and dignity of all individuals, especially those with disabilities, are protected and upheld. Thank you.
Thank you, Vikki, and thank you for your story with us and with the world. It's just so many times proponents and your average person would just imagine assisted suicide being about what is often termed terminal illness. But in fact, so many people qualify for lethal drugs in legal states. It's actually hard to understand what the parameters really are when 6 months or less, with or without treatment, with or without access to care, is the real litmus test here. It's like, I'd like to just, anyone who wants to learn more about why Vikki continued to say that this assisted suicide laws target people with disabilities can look at the website endassistedsuicide.org. It's about a lawsuit that our 501c3 Institute for Patients' Rights, as well as the organization where Vikki works, CALIF, we're suing the state of California for having passed an inherently discriminatory public policy because all people who qualify for lethal drugs are people with disabilities. So with that, Heather, please take the floor.
Well, thank you, and thanks for having me today. And Vikki and Jules, thank you for sharing your personal stories. I also have a personal story. I'm a healthy individual, right? I'm very happy in my life today. I'm a mom. I'm married to my husband for over 20 years. I grew up in a two-parent household, very loving, never wanted for anything in my life. But I suffered from a mental illness as well because I had anorexia. Now, for years, I was able to hide it and, avoid what was happening to me by simply saying, I'm not hungry, I'm fine. I went to University of Wisconsin-Madison, where, I had always excelled at school very well when I was in high school and middle school. And I found college to be quite challenging. My freshman year, my long-term boyfriend broke up with me. And this is really my beginning of my spiral that happened to me at that time. And again, I was just able to cover up everything that was happening to me. I could avoid eating, But the trouble where I came into was, instead of putting food in my body, I would put alcohol or something else into my body that would allow, became a ravaged smoker as well in those days. So I was either smoking or drinking at the time. And all that did to my brain was just take away all those nutrients, right, that I needed at that time. So I was starving my brain. I was still in my development stages at that time. But when I really hit rock bottom was my brother and sister were also at UW-Madison with me. We had lived together in their last years at school, and then they left. They graduated, and I was there kind of all by myself. No one to look after me anymore. And one night I hit rock bottom, and I called my sister and I said, I need to be done. I can't do this anymore. And I wanted to take my life that night. And thank goodness that I called her, because I would have missed out on so much too, Vikki, just like you, all those beautiful moments in my life. But what I realized, I fought my parents when they came and picked me up that next morning. This was in the middle of the night that I called my sister. She's out in Utah. My parents were up in Green Bay. And my parents were there first thing in the morning, packing me up and saying, you're going to go home with us. You need to come home. I was over 18. Technically, there was nothing that they could force me to do for treatment. I fought them getting in that car. I fought them getting out of the car when we got home. I fought my mom and said such hateful words to her because I didn't want to go see a doctor. There was nothing wrong with me. I wanted to take my life, and that's all I wanted. I just wanted to be done with this world. Thankfully, Jules, I did not have the same experience when I went to my first doctor. She was very compassionate, very skilled in anorexia and how to deal with what I was going through. I should have been put into a hospital, but I refused inpatient care. And so I was required to go daily. Sometimes my mom would drop me off and I wouldn't let her come in, and I would try to leave and just go for a walk and miss my appointment. But I think my mom was always sitting around the corner watching to make sure that I stayed in there. And it was through that treatment really where my life started to turn around. However, before I could start putting food back into my body in the way that it needed to, I had to have a physical, because sometimes when you start back into the process of eating again, you can actually shock your body in a wrong way, and something terrible could happen to you. So I went to our normal family physician, and I walked in, and he's like, well, Heather, I don't know what's wrong with you. Why would you ever do this to you? So that was my moment of, wow, the normal medical field doesn't really understand that this is a mental illness. This is not something I'm choosing to do to myself. This is a mental illness. I need help. I'm suffering from depression at the same time. I'm not feeding my body. I need help to turn this around. So after that visit, I was able to go back, start my program. But what I always reflect on is I wasn't doing this to myself. I had a mental illness. I needed some help. So through tools of therapy, tools of medication, I was able to turn my life around. And it's not something that happened overnight, but I will tell you, if those drugs to kill myself were easily accessible through a doctor here in Wisconsin at that time, I would have 110% gone and got that prescription and taken them and been done. And I again look at my life and what I would miss out on today. I get to do something I'm passionate about every single day, help the most vulnerable in our state here too. And I would have missed out on all of that. And I'm so concerned as they look to expand all these illnesses into what this looks like. Anorexia is treatable. It's not terminal. It is something that, yes, maybe it's lifelong. You kind of have to fight things, but I was not going to die from a terminal illness at that point. I was, someone that just needed to be loved and fed. But I think about this all the time. I had advocates who came and took care of me, took me out of my situation that I was in. What about all the people who don't have those advocates? And I think all of us here today experience that on a regular basis. We have to be the voice for those people. We have to stand up for the disabled. We have to stand up for those who are vulnerable, because it's so easy to be told, you're worthless, here's an easy out, and let me help you do that. And we cannot allow that to happen in the country that we live in this world. So thank you so much for allowing me to share my story with you.
Wow, that's so powerful. I mean, some of what, I mean, it just boggles my mind that in legal states who are helping people in just the exact same spot that you were in to kill themselves with lethal drugs. Exact people who are charged with helping them to thrive.
Absolutely.
Thank you for sharing. And last but certainly not least, Nicole Hayes, please share with us.
Absolutely, Matt. Thank you, and good to be here with you all today, and certainly a privilege to be on the panel with you all, each of you who have shared your personal stories. I am, while I do not have a personal story to share, certainly help those who do. For those who are watching, I'm an African-American woman and wearing a black top and gray, chocolate gray scarf and eyeglasses. My name again is Nicole Hayes. I serve as the Executive Vice President with the American Academy of Medical Ethics, which is the 501c4 of our 501c3, which is the Christian Medical and Dental Associations. And the Christian Medical and Dental Associations, I am grateful to serve with folks and healthcare professionals who do have a conscience and ethics that wants to subscribe and be committed to the Hippocratic Oath that says do no harm, that they will not prescribe a lethal prescription to a patient, that they do believe as being a healer rather than killing their patients. So we have about 13,000 members with the CMDA across the country, and truly I do get to serve with healthcare professionals. And I say the word professional on purpose because I think it's typical to use the word provider. And we typically think of someone as a provider in our nomenclature as someone who's more like a vending machine and just basically capitulates to the whims of the patient without actually prescribing, solutions that will actually help to come around that patient and help them to value their life at all stages. So I do have a PowerPoint that I'm going to share, and to preface it, and this PowerPoint will be available after today's webinar. I work in policy, public policy for the CMDA and the American Academy of Medical Ethics. And through that work, I work in the 50 states and in the District of Columbia, where I'm based, with a number of our members and state directors, and of course, Patients' Rights Action Fund, and our partners in all of those states and other coalition partners to help advance biblical and ethical policies that will help advance human flourishing truly in the states and here in DC. So when we're talking about assisted suicide, we are working to protect all of those who are in the states that are right now. We've got about 20 states plus 4 others that are have either looking to legalize assisted suicide or looking to expand. California, Colorado, New Jersey, and Washington all have expansion bills right now. So in that essence, what I'm working to do is to help not only fight that, but also help to pass a healthcare conscience protections, which will allow doctors who are ethic and morally sound, want to be able to practice medicine, but they don't want to be compelled to do the things that a lot of these policies are asking them to do. So I'm going to share my screen here, just a moment here to show the PowerPoint. Give me just a moment here while I pull this up right quick. Here we go. So if you all can see my PowerPoint here, again, as I talked about earlier, we are looking to advance policies and that really subscribe to the commitment of the Hippocratic medicine, which by our ethics has been around for 2,000 years. And it basically it says everything that I will do no harm, I will care for my patient, not here to kill my patient, here to help them value their lives at all stages. With this in mind, we want to help make sure that doctors who subscribe to the Hippocratic Oath are able to practice medicine as it aligns with their faith and their values. We know that our society is continuing to move further and further away from the Hippocratic medicine, and therefore we want to pass healthcare conscience protections. Healthcare conscience protections, like I said, it helps to ensure that for healthcare professionals, students, residents are able to practice medicine as it aligns with their faith and their values. We conducted a survey of our members. As I mentioned, we have about 13,000 members. We have surveyed about 1,700 of those members who indicated that 91% of them would not want to practice medicine if they were forced to violate their conscience. And so that is a high number of folks who would be, if they were not able to practice medicine as it aligned with their faith and values, they would be removed from the healthcare field, thereby limiting the ethical options that would help to extend life and the value and the quality of life for patients who are seeking other options from, and basically seeking to have healthcare professionals who align with their beliefs, their morals, and their values. So as I say here, this gap would significantly reduce the amount of ethical healthcare options for medical professionals and for patients. And it was also surveyed, reported that 81% of Americans said it was important to have healthcare professionals who share their moral beliefs. So with that, we had two lawsuits that we filed against, one against the state of California, one against Mexico with regard to their assisted suicide laws. We talked about a little bit about the California law a little bit here. That law signed into law, Senate Bill 380 in October 2021 by Governor Newsom, reduced the waiting period from 15 days to 48 hours, which is just incredibly hard to even wrap your brain around. But what happened with that law is that it did not allow healthcare professionals the conscience objection to say that they would not only have to, that they objected from having to participate or prescribe the prescriptions, but it also would require them to make a note in the patient's chart, basically saying that they had made an oral request for assisted suicide. And that even makes you complicit with the evil of assisted suicide. And so once that oral request is made, it begins the 48-hour clock, so to speak, of beginning the clock toward assisted suicide. So we decided to file a lawsuit against California. So in doing so, we filed a lawsuit in February of 2022 with the help of Alliance Defending Freedom, filed a lawsuit against California, state of California, Christian Medical and Dental Associations versus Bonta, filed a lawsuit, and we won a preliminary injunction against the lawsuit, which enabled us to put California's law on pause while the lawsuit proceeded, and allowed our members to basically be able to continue to practice medicine as in line with their faith and their values. And in September 2022, the federal court granted our motion. And by May of 2023, California agreed to a settlement which it vowed to no longer force doctors to participate in physician-assisted suicide, and it also covered legal fees for those involved. Then moving on to New Mexico, in 2021, New Mexico enacted the Elizabeth Whitfield End-of-Life Option Act. Here, again, healthcare professionals were not able to object or be removed or be alleviated from having to violate their conscience, in which they were being asked to record and inform their patients about assisted suicide, along with other options, but of course, having to inform their patient about assisted suicide, which would go against their conscience violation. So they would, if they did not do this, they would be at risk of losing their medical license for not complying. So once again, we, with the help of Alliance Defending Freedom, we filed a lawsuit against the state of New Mexico in the case of Lacey versus Vallière, and one of our members, Dr. Mark Lacey, was a member who was a plaintiff in the case. And in April 2023, we didn't have much long to wait. April 2023, the U legislature unanimously passed the law enabling the governor to sign Senate Bill 471, which allowed our healthcare professionals to refuse to participate in assisted suicide for conscience objections. So the case, because of that being signed into law by the governor, we were Alliance Defending Freedom dismissed the case since the passage of Senate Bill 471 satisfied the initial complaint. So to that end, we're really very grateful for the way that those two cases went. We could not do that, have that victory without the help of our partners with Alliance Defending Freedom and all the plaintiffs who helped to bring that case to victory. So what does the lawsuit victory mean for patients and healthcare professionals? Well, it means that patients will have wider access to better and ethical healthcare options delivered by healthcare professionals who align with the patient's morals and values and beliefs. Patients will not be made to feel like it is their duty to die, as several of you have said here on today's webinar, that feeling like it is your duty to die, because they will have healthcare professionals who are committed to the essence and traditions of the Hippocratic medicine that will help patients be able to live and value their lives at all stages. And also the patient-physician relationship founded on trust will be upheld. And finally, states with healthcare conscience protections will be able and motivated to recruit and retain such healthcare professionals and thereby best serve the healthcare industry and the patient, which is so important. And so I'll make this available after the webinar, the PowerPoint, but just hearing the stories that were shared here today, it's so important that we have healthcare conscience protection. So it's one of the issues I'm working on in several states to ensure that healthcare conscience protections are passed in every state so that those of you who want someone who will value your life at all stages, who will not be committed to ushering you down a path of suicide, that you will have someone who will be able to walk alongside you at all stages of your life and offer you options outside of and not offer you options of assisted suicide. So grateful to be here with you all and grateful to do this work with our partners and coalition partners in multiple states across the country.
Thank you, Nicole. Yes, lawsuits like that and standing for conscience, no matter what the background of the person is,
Yes.
there are people from all walks of life and various worldviews, medical professionals who do not want to participate in this.
Correct.
And that needs to be protected in great part because if it's not, then patients won't have choices, not real ones. When the only medical providers that are available are potentially going to devalue your life and consider it not worth living and help you in a dark moment to kill yourself. That's where, you know, patients are put at even greater risk by not protecting those folks. So thank you so much.
You're welcome.
I'm seeing that we don't have any questions from the crowd at this point, and we are at the top of the hour. Wanted to take a moment to make a quick correction. I had used the word association when I introduced Patty. She actually says Alzheimer's Orange County. Done. So it's a completely separate entity from the Alzheimer's Association. I just want to make sure that I corrected that and to thank each one of you who had participated both on this panel and the attendees for taking the time and anyone who watches the recording afterwards. So everyone who put together the webinar in the background, in particular our captioner, Angela, who provided closed captioning in real time. So thank you so much to everyone for taking the time, for your advocacy on this, and for really elevating some of these personal stories that are just such really where the rubber meets the road on this issue. It does impact real people. This will hurt folks. So again, thank you so much, and we'll see you all next time.